There'll be group pictures at the start and at the end of the PEP talk. So please show your face in the video. As a reminder, please take the online learning cum evaluation test exercise, OLETE, for mastery of learning, and have a perfect score to get a certificate like the one shown below. Okay. I have placed the link in the chat box already. So let me just inform you that as of August 14 today, okay, there were already 28 who completed the OLETE, okay, from the start up to this as to last time, okay, last week. Thank you and congratulations. Okay, so this number is compared to 22 as of last week. No? So as I said, my target is at least 30. So I'm reaching my target of 30 patient-empowered people. So let's now have a group picture taking before we start in 2 minutes. Okay. 1, 3. Okay, ready? 1, 2, 3. Okay. So let me save it in my computer first. So let's have it. I think there are 2 pages. Let's have another one. Please show your face. Please show your face. Glenn, Gemma, Emelita, Tan. Okay, 1, 2, 1, 2, 3. Let's start. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. What I have in mind in my PEP talk, which may run for 3 years, is to empower at least 30 persons with my family members and my patients as a priority. This is my key performance indicator. I hope you will be within this group of 30. I launched this PEP talk on May 15, 2021 with a module on COVID-19. The second module was on patient empowerment. I'm now on my third module, patient management process. There are 6 parts in this module: overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, and peculiarities and limitations of medical practice. We are now on this last session, peculiarities and limitations of medical practice. Again, this is the patient management process framework that we have been discussing for the last 5 weeks or 6 weeks. Okay. So my PEP talk today will be entitled Peculiarities and Limitations of Medical Practice. The empowerment objective is for the lay people or patients to have an understanding of the peculiarities and limitations of medical practice that affect the patient management process. The patient management process is essentially problem solving and decision making of a patient's health concern. It is a very complex process in that, 1, it involves a lot of steps like diagnosis and treatment and advice. And in each step, there is a series of actions which are carried out in order to achieve a particular result or goal. And that's the reason for calling this the patient management as a process. Second, although there are guidelines in the use of the processes in achieving a particular goal, implementing them do not always ensure attainment of goals. The main reason for this is that there are peculiarities and limitations in the science of medicine and its practice that pose challenges and hindrances in accomplishing the goals 100%. All physicians are fully aware of these peculiarities and limitations and have adjusted to them and have factored them in their management of their patients. All patients or lay people like you should also be made aware of, at least, if not fully understand, these peculiarities and limitations so that they can adjust to them and factor them in their management of their health concerns and issues. This awareness will also facilitate their participation in the problem solving and decision making with their physicians, in the sense that both parties are aligned in the understanding of the peculiarities and limitations of the science of medicine and its practice. By the way, when I am using the word peculiarities in the title, okay, I use it to mean eccentricity. That is, deviation from the established pattern or norm or from the usual. I may also use it to mean idiosyncrasy. That is, unusual feature or behavior. I am using the word limitations in the title to mean the greatest amount, greatest extent, degree of something that is possible or allowed, but not able to achieve the full capability. As we discuss this topic, please have in mind the patient management process as shown on the center of the screen. At the same time, have in mind the peculiarities and limitations of the science and practice of medicine, and see how the latter affect the former. So these are the maxims, rules, and guides in the management of the patient in consideration of the peculiarities and limitations of medical practice. First maxim is medicine is an inexact science. I repeat, inexact science. Medicine is an art of probability. There are a lot of uncertainties here. Anything is possible, but we usually use the art of estimating the probability of things. The ideal goals or fighting targets in patient management by physicians are the following: resolution of the health problem in such a way that the patient does not end up dead, with no complications and no disability as much as possible, and in such a manner that the patient is and the relatives are satisfied. Now, because of the limitations of medicine, the ideal goals or targets in patient management cannot be achieved all the time. What is most important is that the physicians exert their best, rational, honest, humane, or compassionate efforts in managing patients to the satisfaction or delight of the patients, even in the absence of complete resolution of the health problem. Fifth maxim is best effort by physicians at all times, cure sometimes, relief often, comfort always. Nothing is absolute in medicine. There are exceptions to the rules. Anything is possible. There are more than one way of doing things in medicine. There is no such thing as absolutely certain diagnosis, whether it be clinical, meaning using signs and symptoms, paraclinical, using laboratory, histopath, and or post-mortem diagnosis. Even the diagnosis at death is not totally absolutely certain at times. The only routine in medicine is rational decision-making in the management of a patient with a health problem. Rational decision-making weighs the probability of being successful in the achievement of the goals of the management of the patient. Rational decision-making relies more on the general rules rather than on the exceptions. It banks on the more common rather than on the least common or rare events. It uses processes rather than gut feel. It may not always be correct. As long as the decision-making is rational, it is acceptable. A rational decision-making is more often correct than wrong compared to an irrational decision-making. As to the diagnostic process and the diagnosis, some of the maxims, rules, and guides here are: the diagnostic process must be rational for it to be acceptable. A diagnosis that is based on the rational process is not always correct, as mentioned. However, a diagnosis is more often correct than wrong if it is rationally arrived at. A diagnosis is almost always an educated guess. An educated guess. As to interview as a diagnostic tool, identify the chief concern or main problem of the patient. Once it's identified, we use it as a steering wheel in the diagnostic investigation of the patient. Inquire on the circumstances associated with the chief concern. Inquire on the symptoms. Symptoms are defined as those manifestations perceived by the patient in terms of feeling, in terms of observation. Get clues from the circumstances and symptoms to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Then know how to get cues from the data and know how to interpret the data. Know which data to pursue, which data to put in the background, to use in the diagnosis, and not to use in the diagnosis. Physical exam as a diagnostic tool. Use again the identified chief concern or main problem of the patient as a guide on what to examine. Okay, that's why doctors usually from the very start ask the patient, what is your main concern or main problem for coming to see us? Okay. So that's the starting point of everything. Okay. So use that and then look for signs. Signs are those manifestations perceived by the physicians, in contrast to symptoms, which I defined earlier. So these are felt or observed by the patient, symptoms. Okay. Get clues from the signs to be used in the diagnosis of the patient. Be effective, be complete, be efficient, be relevant. Know how to get cues from the data of the signs and then how to interpret them. Know which data to pursue, to put in the background, to use in the diagnosis, and not to use in the diagnosis. As to interview and physical examination, which are the main tools in the clinical diagnosis, so interview and physical examination can be done in any order as dictated by the circumstances. Interview and physical examination can be done simultaneously. The goal of the interview and physical examination is diagnosis, clinical diagnosis. Correlate data from the interview and physical examination to come out with a rational clinical diagnosis. If there is a question on which data to put more reliance on, we usually choose the sign data over the symptom data because sign data are more reliable. But to be reliable, they must be accurate. Okay? They must be accurately derived at by the physician. The clinical diagnostic process. A clinical diagnosis is one that is derived from interview, getting the symptoms, and the physical examination, getting the signs, or put it in another way, one that is derived from the symptoms and signs. Essentially, the two processes used in coming out with the clinical diagnosis are pattern recognition and prevalence. So pattern recognition just means the realization that the patient's presentation conforms to a previously learned picture or pattern of a disease. Whereas prevalence means the choice of a diagnosis is based on the frequency of occurrence of the disease in a certain locality, in a certain age or sex group, in the affected organ and system, and I would like in a certain time, just like today, we are in the era of COVID-19 pandemic. So we have to put that into consideration when we have symptoms of upper respiratory tract infection. The elemental steps in making a diagnosis: identify which organ, tissue, or system is involved, then identify the disease in general terms such as inflammation, infection, tumor, trauma, endocrine, etc. Then try to be more specific in identifying the disease, if possible, such as malignant neoplasm, abscess, etc. Knowing the nomenclature of diseases facilitates the diagnostic labeling. As to the paraclinical diagnostic process, so after the clinical diagnosis, the next step is to determine whether a paraclinical diagnostic procedure is needed or not. The paraclinical diagnostic procedure is a diagnostic procedure that is done after the clinical diagnosis is arrived at, and its objective is to make the clinical diagnosis more definite, more certain. To decide whether a paraclinical diagnostic procedure is needed or not, a physician should consider the following factors: how certain he is with the clinical diagnosis, whether a more definite diagnosis is needed or not for one reason or for some reasons or another. Once a decision is made that a paraclinical diagnostic procedure is needed, the next step is to choose the most cost-effective procedure for the patient by doing the following. The physician usually or should tabulate, compare, and analyze the options listed on the first column and give the so-called BRCA data like this. B stands for benefit, R stands for risk, then C, cost, then availability. Putting priority on benefit, then risk, then cost, availability in that order of descending order. Okay. After the paraclinical diagnostic procedure has been done, the next step is to interpret the result. The result of the paraclinical diagnostic procedure must be correlated with the signs and symptoms of the patient to come out with a pre-treatment diagnosis or a diagnosis just before the treatment. Selection of treatment process. The selection of treatment procedure is based primarily on the pre-treatment diagnosis. Select the most cost-effective treatment for the patient by doing the following: tabulating, comparing, analyzing the different options placed in the first column, and then give the BRCA data, okay? Benefit, risk, cost, and analysis. The final decision on the type of treatment to institute will rest on the patient. So the doctors will have to get the informed consent or informed refusal if the patient does not want to. I will now go to the two special issues related to the limitations of doctors or physicians: knowing when and to whom to refer, And then the other issue is second opinion. Let's start with knowing when and to whom to refer. There will always be patients whose health problems will be beyond a physician's existing competencies. Such patients may have a very unusual health problem whose diagnosis is extremely difficult. Such patients may have usual health problems, but whose treatment is beyond a physician's existing competencies. For example, a primary care physician, or the usual terminology used here is GP, okay, who has not been trained to do a surgical operations. True to all physicians, regardless of the amount of training and experience, there will always be patients whose health problems are beyond their present existing competencies. This applies to me also. So when to refer, all physicians must know their limitations. Only they themselves can determine their own limitations. They must realize their limitations so that they do not cause undue harm to their patients, and so that they know when to refer to their colleagues. When you say refer, it means asking for help from and conferring with medical colleagues. Referring a patient to a colleague may mean totally transferring the care of a patient to him or continuing to manage the patient with his help. Whichever way, a proper communication, either oral or written, is in order. Referral must be made to somebody who may or can solve the patient's health problem rationally, effectively, efficiently, and humanely, and who has a good track record of handling the kind of problem on hand. Now let's go to second opinion. Second opinion means seeking another opinion on patient management from another physician or healthcare professional. It can be sought by both physicians and patients. Physicians seek second opinion from medical colleagues when they realize their limitations, when they are beating their heads against the wall in trying to know the true diagnosis and how best to treat the patient. Physicians can informally communicate with their medical colleagues from whom they want to seek an opinion, or they can formally advise the patients by giving a referral letter to seek a second opinion from another physician. Patients on their own free will seek second opinion from another or other physicians for at least two valid reasons. First reason is they are not fully satisfied with the explanation of the first physician, either because there is no or incomplete or unclear explanation. The second reason for patients seeking second opinion is that they want to validate the explanation and recommendation of the first physician. The usual scenario is because they are hesitant to accept the recommendations, and they hope there will be different recommendations from the next physicians congruent to their personal desire. Here is a special note. Seeking another physician is not always equivalent to seeking second opinion. Seeking another physician may have other reasons aside from second opinion. An example, patients may be primarily shopping for physicians who can offer the best or especially affordable medical expenses. Another example, they may be looking for other physicians whom they can communicate better and with whom they have better rapport, trust, and confidence compared to the first physicians. The third example is that they may be looking for other physicians because of convenience of continued medical care, such as physical proximity of the clinics of the physicians, and their affiliated hospitals. All patients have the right to seek second opinion for whatever reasons they may have. Nobody will, can, and should question the reasons. So the basis for this right is that patients have the right to make their own choices and be the primary decision maker with regards to their health concerns and issues. They have the right to seek medical opinions from another physicians after the first and to as many physicians that they want. But the foremost objective, valid indications for second opinion should be if the first physician is not explaining or advising well using the rational patient management process and the diagnosis and treatment. So this should be the most objective indication. If he does, there may be no reason for a second opinion. If he does not, then there's a need for a second opinion because that physician is not advising the patient well enough. It is not wise for patients to seek second opinion all the time, only as needed or as indicated. There are benefits as well as potential harms in second opinions. A benefit is the facilitation of problem solving and decision making. Potential harms could be confusion because of so many differing opinions, either getting the wrong advice, doing the wrong problem solving and decision making. Simply going by plurality, 3 against 1, 4 against 1, something like that, plurality of opinions is not as strong, not to say valid, reason for seeking a second opinion compared to the foremost indication mentioned above. The foremost indication as mentioned is that a physician is not explaining the process well. Going by plurality of opinions is no assurance that the recommendation is correct or should be adopted. One may end up choosing the most popular medical opinion because of the plurality rather than the most rational one backed up by good processes. So if one seeks second opinion, beware of the danger of seeking from physicians who do not use the patient management process to explain and advise. The advice given may be just based on current trends and fad and not based on an in-depth analysis of the patient's actual medical conditions, inherent psychological makeup of the patient, and not based on concrete medical data, information, and evidences. So I'd like to end this pep talk at this point. Okay. The takeaway in this pep talk that are related to patient empowerment are the following. Understand the peculiarities and limitations of medical practice as they affect patient management process so that you will not be frustrated with the outcomes. Be ready to ask questions if the physician is not advising you properly and adequately on the peculiarities and limitations. Participate actively and fully in the problem solving and decision making of your health concern with your physicians, factoring in the peculiarities and limitations of medical science and practice. And lastly, the last takeaway is to master the peculiarities and limitations of the medical science and practice as they may help you in some way in deciding for your own health concern in consideration of the oddities. This is one other way of gaining greater control in your health concerns and issues. Now, before we go to the question and answer, or picture taking first and question and answer, I'd just like to add something here. So just an announcement, okay. August 9 was the other day. Okay, I updated the design and development plans of the ROJoson PEP TALK. I have transformed it formally into courses. Okay, so there are three types of courses. You have the core course here, okay, and then you have the health disorder courses, and then the health issues courses. Okay, so you know the reason why this is illustrated like a coronavirus, okay, because this was formulated at the time of the COVID pandemic. Okay, so this is the core course. So coronavirus, there are spikes. So these are the health disorder courses, health issues courses that are being represented by the spikes. Okay, so the core courses includes the following: patient empowerment program, which we have completed. Now we have completed, this is the last session for the patient management process. Then the rights in patient empowerment, which will run for another 2 weeks, and then staying healthy and contented. And the last, this will be the last module on this PEP and this core course. Okay. So just to recall your memory, okay. So those who have undergone, who have attended the patient empowerment program module, we talked about what is patient empowerment, strategies in patient empowerment, when is a patient empowered, okay? Then as to the module on the patient management process, okay, overview, clinical diagnostic process, paraclinical diagnostic process, selection of treatment process, advice to patient process, and now we just finished this one, peculiarities and limitations of medical practice, okay? So 2 more core courses that be upcoming. So next week we will be talking about rights in patient empowerment, which will be which have 2 sessions: basic rights, and then patient autonomy and advanced directive. And then the last course for this, the last module on this core course will be how to stay healthy and contented. So first module will be on introduction and intentional living plan, healthy lifestyle plan, screening and periodic health check, early diagnosis and early treatment, and first aid and basic medical care. So all of these comprise this so-called PEP core course, the one on the center. So today is August 14. So we hope if we continue it on every Saturday, we hope to end the last session for the core course on October 2. Okay. So at the end of the October 2, for those who have completed all the OLETE, I will be issuing certificate of proficiency in patient empowerment. Okay. So this is for the entire core course. Okay. Now for the health disorder courses, so these are sample courses, okay? So we have gone through COVID-19, that's done, okay? I won't repeat it anymore. This is despite the search. This is the 3rd search that we're having now, okay? So I just leave it to the public to read my PEP talk in the internet, okay? Then another sample course of health disorder course will be cancer, breast disorder, thyroid disorder, skin and soft tissue disorders. Okay, there will be more. Okay, there will be more. Okay, example of health issue courses will be end of life management, okay, which is also very important. Palliative care, use of supplements and vitamins, patient-centered care, unnecessary operations, unnecessary medications. So these are just sample courses which I still have to formulate. So at the end of the, somebody who will finish the core course plus 2 courses from the health disorder courses and 2 courses from the health issue courses will be issued now a certificate of mastery. Okay, kanina, certificate of proficiency. So this time it will be certificate of mastery in patient empowerment. Okay. So before we leave, before I formally end this PEP talk by PowerPoint presentation, I'd like to remind everybody again, take the online learning CUM evaluation test exercise for mastery of learning and have a perfect score to get the certificate. Okay, I have placed the link in the chat box. I'm going to place the link also in the Facebook and Viber group. So I hope I have empowered you to have a greater understanding of the peculiarities and limitations of medical practice that affect the patient management process. Okay, so this ends my slide presentation. So we will now have a group picture taking before we start the question and answer and interactions. Please turn on your video and show your beautiful faces now. Ready, get set, get all your pictures, video out. I'll start with page 1 muna. Mas kompleto yata yung page 1. Okay. Okay, 1, get set, ready, go. Give me a second to save it. Then page 2. Page 2. Okay. 1, 2, 3. Okay. Save it. Okay. So the floor is now open for questions, comments, suggestions, etc. You can place your questions on the chat box, or you can raise your hands through the, there's an icon there, okay? Or you just unmute yourself and shout out your questions, okay?